Hello friends, myself Dr. Surendranath Reddy. I am here to introduce you a personality who has done his BDS from Government Dental College Vijayawada and MDS Oral Maxillofacial Surgery from Kamini Institute Hyderabad. He has he has been the topper of the university in his MDS and he is a gold medalist too. We are very fortunate to have such a teacher. He is working as a professor in Medicity Medical College, Hyderabad, and he has been into this basal implant from past 6 years. I have known more than 200 plus dentists who has taken a hands-on course from this famous personality. I am very fortunate and grateful to introduce you to none other than Dr. Sumant Krishna, MDS Oral and Maxillofacial Surgeon, and he is the best teacher you can ever have. This is my promise to you. I would take a pleasure to invite Dr. Sumant sir into the dais. Sir, please come and take all the dais is yours. Thank you. Sir.
Thank you, Dr.
Thank you,
Surendra.
sir.
Thank you very much.
Thank you guys.
Hello, guys. Hope you are all doing well. As Dr. Surendra mentioned, I am Dr. Sumant and I am a practicing OMFS surgeon. Hope you are all doing well, right, in your all clinical practices and all. And I first of all, I congratulate you, all of you. You have taken enough time, to upgrade your skills in the branch, of implantology, of learning about the corticobasal implants, right. So, before I even venturing into the topic, right, so the topic is the clinical course on basal implants. What is exactly the necessity of basal implants in today's world? That is what we need to know, right? So, see, I'm sure in all the people attending this module today, right, a lot of you guys, would have been practicing already two-piece implants or the conventional type of an implants, right? And somewhere, you would have had, a lot of cases, basically, where I can say, it's not ideal, to place a two-piece implant and you are looking for some other alternative, right? So, today we are going to actually, talk in brief, I can say an introduction to the corticobasal implantology, right? So that it will give you a brief insight into the various modes of treatment for an edentulous condition, right? So, to start with, what exactly is the today's necessity of basal implants? Right, I would like to, the next, what is this all about? What exactly are we, discussing today? Right. Now, why are we gathered here first of all? In the first place, why are we gathered here? Right. So, when, a lot of confusion is there in the mind, I have already been practicing two-piece implants or, a basal implants what exactly is there in this? Right or wrong, right? So these questions, when I was even a student, right, when I was even pursuing my master's degree, right, so that time only the two-piece implants were actually in a full flow, and that time even my teachers have taught me, this is the only implant that is going to rule the world, right? But whenever there was a condition, whenever there was a situation, right, where two-piece implants was not so successful, right, people started then looking out for an alternative, right? So what is that exact alternative? And I strongly believe somewhere in your minds also, right, so you would have that doubt thinking, even let me attend this course so that ek patient aaya tha mere ko, means one patient I had, who had this problem, but I deferred placing a conventional implant because there was not enough bone, or the patient did not have some time, or whatever the reasons might be, right? So today we will actually introduce you, means I'm going to talk to you about the corticobasal implants, which will actually give you a very clear picture of the conditions where actually you are going to place these basal implants, and how actually the good your practice is going to pick up from here on, right? So all the best guys, first of all, whoever is attending this course. And one promise, one deal I want from you guys, that for the next 1.5 hours, whatever the time it might take, so I promise, the deal is I promise to give my 100%, whatever the experience I have, whatever the knowledge I gained from my seniors, from my teachers, right? I'm going to share, I'm just going to put my heart out. But at one condition, right? So I want your total, I want your total attention towards this module, because otherwise, you might miss a small point which will again start bothering you, right? So I don't want you to miss that points, right? Is it a deal? Right. Then let's just, this is all about the corticobasal implantology, right? So to start with, as all of you know, right, there are type of implants, right? Basically are of two types broadly, if you classify them as like conventional, or we also call them as a two-stage implants, right? And the basal implants that will come later on. So what is this conventional or a two-stage implants? Basically is what you place an implant, right? You just place an implant, right? And then you wait for a certain period of a time called as a waiting time, right? See, there are few of the articles that state, you can place an implant and you can actually load them immediately in a conventional or a two-stage implant. But honestly speaking, are you really in a position to take that chance that I just put an implant, immediately I'll start loading? Not many of you, I believe, because in my clinical practice over almost like 14 years now, right, I would have placed more than around 50,000 two-piece implants, but none of the implants, right, were actually, I actually tried also for immediate loading, but most of them failed. Most of them failed. So it's always better, right? You place an implant, right? Give it time, for it to also integrate, right? And then only you can load it. Otherwise, there is no, the success rate comes down drastically, right? So this is about conventional implants, means where you actually you just place an implant, right? So it's a multiple stages basically, right? You first, place an implant, then you wait for a 6 to 8 weeks time period or whatever the time period you desire to have. After that, then you have to load it by placing an abutment and then over it a crown, right? So these are basically the conventional or two-stage implants, right? Now conventional or two-stage implants, right? Now if you look at the indications, right, people might say that that at any condition I can actually place, right? But what about the resolved ridges? Can you actually place a conventional implant in resolved ridges, or can you actually place them in a aggressive periodontitis case, right? That anyways will come after a little while, right? So basically the conventional implants are a two-stage implants basically, where you just place them, wait for a time period and then move on from there, right? Now what is the second kind of implants, right, is the basal implants, right? Now, the word itself indicates basal or a bicortical, right? Basal or a bicortical. Now, what does the term called, the term like the basal implants indicate to you, right? It means utilizing the basal bone, right? Utilizing the basal bone, right? Or utilizing the two cortices, any of the two cortices. It can be the mesial distal, or it can be crestal or apical, or buccolingual, right? So any of the two cortices, when it is engaging, actually it is called as a bicortical, or more specifically if you ask me, it actually engages the cortical bone, right? It does not engage the cancellous bone, right? It actually engages the cortical bone, right? Now, many of you might be thinking that the basal or the bicortical implants are the new system that have actually evolved, but that is not right. It is an utter false, right? Just because our teachers, they did not teach us about the basal implants or bicortical implants, or we did not come across, or we did not use them in our clinical practices for the patients, right, doesn't mean that they did not exist, right? Now, you might have get a doubt. Then why I didn't know about this? Right? See, always remember, right? Whatever the Western countries want to promote, those are the things that get promoted. Right? Now, in cases of two-piece or basal, I mean, say two-piece or conventional implants, right? There are a lot of prosthetic components that are involved, right? So everything works for money. You understand, right? So, but basal, you require a very, very minimal amount of prosthetic components, right? So by now you understood why actually, we couldn't come to, that is one of the reason. I am not saying that is the reason, right? Now, coming to the history of the basal or the bicortical implants, these have been actually in use for the past almost like 25 years. Now, where did this concept develop from, right? The basal or the bicortical implants, right? Now, if you actually, go back, or if any of you listening to this module, if anybody a surgeon is there, means OMFA surgeon is there, I think you guys will understand, or even the graduates, means the BDS graduates also will understand. If you go back to your oral surgery books, you would have heard about something called as a lac screws, right? So whenever there is a fracture, whenever there is a fracture, right, to actually reduce the proximal and the distal segments, right, a small diameter hole is drilled, right, into the proximal or the distal segment, whichever you want to get it closer, right. A small diameter hole is drilled, right, and a wider diameter screw is actually tightened into it, whereby the proximate the segment that has to be reduced is actually pulled towards, and then the reduction is achieved. So these are being actually used, most commonly in the cases of long bones, and slowly, and it has been actually adapted to the jaw bones also, right? So this is not something new. It is just that we are new to it. It is just that we are new to it. It is not something new. We are new to it. Okay. So this is about a brief history about a basal or a bicortical implants. Now, if you look at, what is the advantages of the basal implants, right? If you look at the advantages of the basal implants, right? One of the oldest concepts basically, right? Completely new design. Now, if you look at the design also, right? What is the major advantage of the basal or the bicortical implants is they have a very aggressive threads. Now, if you look at the structure of the threads there, right? They have a very aggressive threads. They are nothing but like a self-threading ones, right? Which gives a lot of advantage for anchorage. Whereas now, if you see actually in cases of the conventional or a two-stage implants, right, the threads are not so active threads actually, right? And that is the reason in cases of two-piece implants, you have to drill according to the implant size. Let us say if I am putting a 4.2 diameter implant, right, at least in the coronal half, I have to drill with the 4.2 diameter implant at the final drill. Otherwise, the implant is not going to sit inside, because it is not a self-thread activated thread. Whereas if you take the basal or the bicortical implants, right, it is very aggressive threads, right? Now, just understand one point here. Now, I just want you to understand, reiterate one point here. Now, you just take example of our general surgeries only. Forget about for a while, just forget about the dental surgery part, right? Now, if you see where the world is moving, right? Right? Whenever they wanted to, earlier years, means in the ester years, in the olden days, whenever they wanted to even put a small stent in a coronary artery, right? What they used to do? They used to cut open the rib cage, they used to expose the artery, and then introduce a stent. Now, from where it has now gone, from there, from an open heart surgery, it has actually gone to a non-invasive of just placing the stent through a radial artery, right? Now, if you take even in cases of endoscopic surgeries, right, if there was a gastric ulcer, or to that matter, if they want to even introduce, even if they want to, a kidney stone, you can take an example, through endoscopy, through lithotripsy, they are just operating it with just a small keyhole. It means what? The world is actually moving towards a very, very less aggressive approach for any treatment. Right or wrong? Right? So the world is actually moving towards, right, a less aggressive approach. It is no more that, even if you see also the patient's pain threshold levels have actually drastically come down. Right? And people wants immediate results. Right? So when the world is moving at a fast pace, you tell me, can you afford to stay back just because you do not have the knowledge about it? Right? So now if you see the surgical approaches, anyways, that will deal in the later modules, but just give you a brief glimpse of it, right? If you see the surgical approaches of a two-piece implant, right, or the surgical approaches of a basal implant, right, most of the cases in two-pieces implant, you have to raise a flap, which actually in terms of aggression it is little aggressive. But in cases of basal implants, we don't even need to raise a flap for it. Right or wrong? Right? So, when the world itself is moving towards a very, very less aggressive, less, more conservative, right? Obviously, you cannot stay back. We have to move ahead with times. And that can happen only when your mind is open. Right? I know, right? Lot of people who are practicing, two-piece implants are actually attending this module. Right? I'm telling you guys, whoever is practicing two-piece implants, I am not against two-piece implants because I myself have placed more than 50,000 implants in the past 14 years, different systems, right? I am not against two-piece implants, or I am not promoting only the basal implants. I am just here to guide you, to tell you that there is an alternate approach, for the benefit of the patient. It's not just for the benefit of the pocket. It's for the benefit of the patient also, right? So, let us move towards a very, very less aggressive and a very, very less, a more conservative approaches, rather than, creating more pain to the patient, right? We can reduce the threshold, we can reduce the pain levels to the patient, right? In the same day, within just 3-4 days, you can actually, rehabilitate the patient's edentulous condition, right? So now, see, to actually shift from the principle of a two-piece implant, right, to a basal implants, it's not going to be easy, because as a conventional implant practitioner, it was not easy for me, first of all, to accept the concept itself in the beginning, right? But I was actually always open-minded to at least try something new, right? So, whoever is practicing, right, the basal, the conventional implants, right, please have an open mind, right? My request, humble request to you all guys, right, attending this module, who are practicing, right, the two pieces implants, right, please have an open mind, because these concepts are going to cause a kind of a paradigm shift in your mindset, and that requires, if you don't have a paradigm shift in your mindset, it will be a difficult task, and there is no point in attending this module, right? If you really think that, something great, something good, I am going to give that benefit to my patients, then you are the one, actually, you are the one who is going to succeed in the field of basal and the cortical implantology, right? And those people who are not at all practicing any kind of implants, congratulations, you will be more successful than those who are already practicing, right, the two pieces implants. Why? Because there is no conflict of thought, right? Because I was initially, when I started practicing, basal implants way back around 2016 or 17, something, somewhere around that, right? initially, I used to place, I was very, very, very skeptical, trust me. Believe me when I say that, I'm very skeptical. But still, probably once in a month, I used to do, 3 implants or, or 4 implants or something like that. But when I started seeing the result, right, when I started seeing the results, that is when I decided, to go in a big way, right. Then I started placing, wherever I can place a 2-piece implant also, I started placing the basal implants, right. And that is when actually, even in this, I think so in 5-6 years, I would have placed more than 20,000 basal implants, right. And but that will take some time for you to accept it, right. So it's okay. Initially you might not accept it, that's fine, absolutely fine. But over a period of time, they say this, whether you like it or not, you will be compelled to do it. Because the times are changing, we need to change with it. Otherwise, the time only will change you. Got it? Now, so to first of all come to the main topic of this today, this is our brief introduction of the basal implants, right? To accept something new, according to you guys, right? Initially I thought there was a new concept, but when I went and read about the history, I came to know that this is not something new. This is already present, right? So to accept it, first of all, we need to know the main differences between the conventional and the basal implants. Now let us look at these differences, because these are very, 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 very important, right. These are very, very, very important. So for that reason, each point mentioned in the table, right, I am going to explain it to you. Okay, so please pay very good attention when I am saying all these points, because this will actually clear a lot of concepts to you, right. See, if you have any questions, please note them down. If you get any queries or whatever it is, please jot them down in your diaries or wherever, your notepad or whatever it is, right. We will definitely have, at the end of all the modules, we'll definitely have a Q&A session, right. And then that time again we'll try to clarify all your queries, right. Or if anybody interested actually to learn more, you can actually register yourself for a hands-on course also, right, where you will get more clarity, right, because you will be operating directly on the patient's mouth itself. All right. So now first of all, let us look at the differences, right, between a conventional and the basal implants, right. Now the first and foremost difference, right, the concept, the principle itself is the basic difference here, right. First one is what? The fixation, right. Now how does it actually work, right. Now if you see the conventional implants, right, they work on the principle of osseointegration, right. They work on the principle of osseointegration, right. I hope all of you know what is osseointegration, but for those people who are confused with the term, let me just explain it to you, right. Osseointegration is nothing but when you actually place an implant, right, in the bone, right. So basically the implant actually fuses, you can say, right, with the parent bone, right. That is called as osseointegration, right. It firmly binds to the bone, right. That is called as osseointegration, right. Now what is the principle behind the basal or the cortical implants, right? Osseofixation, right. Now what is osseofixation? It does not ankylose to the bone, or it does not fuse with the bone, right. It just fixes, right. Now a lot of you people, in your house, right, you would have some or other time in your entire lifetime, right, you would have actually drilled one hole into a wall and then put a screw into it. It's a similar phenomena here, right, as we surgeons generally do, right, when we actually reduce a fracture, right, what that we actually fix them with? A mini plate and screws, right. The only difference there and here is it has a screw head there, but here the implant itself has an abutment along with that. There is no separate abutment actually you have to place. So that's why it is also called as a single piece implant, right. So it basically rigidly fixes into the cortical bone, right. So that is called osteofixation, right, whereas in conventional implants it is called as osseointegration, right. So that is the basic principle behind the concept of both the basal and the conventional, right. And if you look at the success rate, if you look at the success rate of conventional implants, right, it is around 95%, right. It is around 95% of success rate is there. It's good numbers, right or wrong, right. It's a really good number, right. But if you look at the success rate of the basal or the bicortical implants, it is around 98 to 99%, right. See, these are not the figures, all, don't think that these are all very fanciful, that I am just coming and telling you here, right. Before coming and telling to you here, or even before so many workshops I have conducted, or I have mentored, I have taken, right. But all before all that hard work, I have done another hard work of going through the articles also, right. If you are interested, right, I think it is available in Google also, right. There is one article called as a Brazilian Journal of Oral and Maxillofacial Surgery, right. Now what they have done, why I am suggesting this article, and there are so many Indian authors also, right. If you go to Journal of Oral and Maxillofacial Surgery, JOMS, right, or Brazilian Journal of Oral and Maxillofacial Surgery, right, there are a lot of articles, right. You can go through them about the success rate, right. In this one particular journal what I was mentioning about, right, now there was this article, right, where they have done a clinical study with a 5-year follow-up of, by placing, they have selected patients of age group of approximately from 25 years to 70-year-old patient. Means which involves not only full mouth rehabilitation, it also involves a segmental rehabilitation or a single tooth replacement. All together, right, they have placed approximately 1024 implants, basal or bicortical implants, right, and they have achieved over a 5-year follow-up period, right, they have achieved a success rate of 99%, right. They have achieved a success rate of 99%, and it is not an ordinary thing to achieve, not at all an ordinary thing, right. Now you might wonder, right, what big deal, it is having 95%, this is having 95 or 98 to 99%. It's only a matter of 2 to 3% or 4%. But if you look at the number of implants you have put, if you have put 10,000 implants, or if you have put 20,000 implants, right, or even to the matter 2 to 5,000 implants also, that 1 to 2% difference is also a huge difference in the success rate, right. So there is a huge difference. So don't think that 95% or 99%, not much of a gap is there. No, but there is a huge difference in that numbers when you are actually seeing in the large number of implants that you have placed, right. So if anybody interested, you can actually download it from the Google. Actually I think it is available still, right, because I subscribe to it, I got it. It is available, I think so, in Google. Please go through it, and then you will get a much more detailed information about the success rate, what are the parameters they have taken, right. So all these things will come there, right. And now what is the third difference is what is the loading time, right. Now loading time, when you take for a conventional implants, minimum, bare minimum, right, is around 6 to 8 weeks, is around 6 to 8 weeks, right or wrong, right. It's around 6 to 8 weeks, right. But now let us say, for example, if there is a cyst, if there is a periapical cyst or a radicular cyst, let's say only a 0.5 or 1 centimeter in diameter, 1 into 1, right? And then you have done the enucleation, whatever the grafting you have put, you have done whatever it is, but still, or if there is a bigger defect, right, you need to wait for more number of time. Sometimes it can go up to 6 to 8 months also, right? See, there was this one case when I was actually doing one, in my post graduation days, right? There was one case what we operated. The patient had a totally resolved ridges, right? So what we did, we harvested the ilia graft, right? And then we did the augmented the ridges, both the maxilla and the mandible both, and we nearly waited for 8 months, right? 8 months we have waited, and then we have given the implants. But you know what happened? After exactly 2.5 years, this was done in my first year of PG, I think so, and when I came to the final year, the patient came back again. Why? The upper maxillary was a failure. Let's not go into the reasons. So there are chances, right? But in those days, if we had an option, right, of a basal or a bicortical, there won't be requirement of any second surgical site for the patient, right? So loading, when you actually want to give, you have to wait for a minimum number of time, right? Say 6 to 8 weeks or 6 months or 3 months or 8 months or what, depending upon the condition of the patient. In conventional implants, see, mandible still you might take a chance, but maxilla you can't never take a chance because of the porous nature of the bone, right? So in cases of conventional implants, the loading cannot be immediate, right? Now if you take the basal or the bicortical implants, the loading period is immediate. I'm sorry, the loading period is immediate. You can actually immediately load if you have a proper load, if you have a proper lab support, right, in your areas wherever you're practicing. You can actually load them immediately the same day itself, either with a provisional or with a permanent prosthesis, if you have a proper lab support, right? So you need not wait. So you are cutting down the waiting period. You are actually cutting down the total waiting period, right? But whereas in conventional, I already explained to you, you have to wait a lot of time, right? Now just imagine, just hypothetical, let us say, but I'm sure you would have faced this situation in your clinical practices, who your seniors, who have been practicing for a decade or more than that, they will understand what I'm saying, right? You would have got a lot of patients, who come from abroad. They say that, doc, I have only 1 week's time, but I don't want, I don't want my other teeth to be grinded for the sake of, building this one. So what you will do? Can you take a risk of placing a 2-piece implant, immediately loading it? Because the next year when the patient comes back, it will be a failure. Your reputation is at stake. So understand this. Why I'm saying this is, I'm not trying to demotivate you, but there are these such type of cases, they come. 110% such cases do come. Right? In my clinical practice, there are n number of cases, who have said that, no, next week I'm flying down. I have to fly. I have to fly to US. I have to fly to Australia. Right? It's not easy to to lose a case, because at the end of the day we all require money, right or wrong, right? So the basal implants, right, when you have learned the technique of basal implants, now you immediately say, no problem, we can deal with that, right? Within 3 days, I can give you your tooth and you can happily fly, no problem at all, right? So loading of the basal or the bicortical implants is immediate. So there is not much of a waiting time, right? Either with the provisional or with the permanent, right? And next difference is that when it comes to sizes and designs, right? Conventional implants have a very limited sizes, means limited sizes or designs. There doesn't have multiple sizes or designs. They have, but they are very minimal, right? But when you come to basal implants, you get a huge variety. You have extremely polished surfaces, you have a smooth surface implant, you have a rough surface implant, you have a compressive implants, right? And you have a combi implant like in GS implants. What these guys are producing, amazing product, right? These guys have like a combi also, where there is a rough surface and a smooth surface in the same implant, which is actually very very beneficial in cases of extraction sockets, right? So these, they have a multiple sizes and they have a multiple designs that are actually in place when you can you have a lot of options in cases of basal or bicortical implants, right? Whereas in conventional there are only limited. All right. So next, coming into bone augmentation, sinus lift or graft. Now, let's be very honest. See, I don't mean to demean anybody here, right? If anybody gets offended, I'm extremely sorry for that. But how many of you, right, are actually trained? I'm not saying that you should know it by day one. How many of you are actually trained to do bone augmentation procedures or a simple like a sinus lift or do a grafting procedure, right? Most of you are not. Let's be very honest. Even I was not when I did my graduation. It's only when I did my post graduation I learnt it. Few of you might be there. I am not denying that. Okay. Few of you might be there, right? Who would have gone for workshops or whatever it is and then learnt it, right? But in a setup like when you in a setup like our own dental offices, right? Can you actually if there is a thin shallow ridge, you want to do a bone augmentation, right? And mind you, there is no graft better than an autograft, right? You might be saying, what big deal? There are artificial bone grafts available, alloplastic. You can just fix them, right? Guys, if you're thinking like that, please wake up and smell the coffee, right? With a lot of experience in that, I have burned my fingers. Let me be very honest. I don't feel ashamed in accepting my faults, right? I have burned my fingers, right? Trying with allografts, right? And then thinking that they will work, right? Just imagine anything that is a foreign, right? It has high chances of causing an infection in the body, right? The body has every right to reject it, and lot of times it happens, right? See, because you would have done, probably the patient did not come back. You might think that it was successful. Who knows? He would have gone to another dentist with the same problem, saying that I went somewhere and they put something and then I got an infection, right? So the chances of rejection of the graft, if you're using an allograft, right, are very high, right? So let us be very honest and say that a simple symphysis graft you want to take, simple, right? I'm sure not many of you, I'm not discouraging you. Some people might be doing, right? Some people might be doing it, right? But most of them, most of you guys or most of the people around, right, they will not be trained enough to actually just cut open the vestibule and then expose the symphysis, and certain times you don't have the armamentarium also to do that, right? So again, you need to call a specialist for that, or you need to call a consultant surgeon for that. Again, the cost of your treatment will go on increasing, right? It is even heavy for the pocket of the patients, right? So owing to all this, now for even a sinus lift, right, I have gone, right, I have gone so many times to consultations, right, where people have tried to do an indirect sinus lift also, right, and accidentally, right, while tightening or whatever it is, right, the implant has actually gone into the maxillary sinus, right? So it's a big nuisance, right or wrong, right? So you immediately start panicking, right? So to avoid all these things, now if you look at plants, right, you don't require any kind of bone augmentations, you don't require any kind of grafting, right? Even if there is a cyst, even if there is a cyst, I still can place the implant, I still can load it immediately. I need not wait. There is no waiting period. Right? So it is, if you understand, for a beginner also who has not done an implant till date, right? This is the best concept. Actually, he can start it from day one, from today only. Right? Which will give him a lot of confidence. Right? It's such a simple technique. Right? In the practical module, when I am showing it on the models, you will understand. Right? It's very, very easy. Right? Just that you need to have that anatomical considerations. That's it. Right? So, coming to the difference, there is no need of any kind of bone augmentation. There is no need of any kind of sinus lifts, grafts, nothing in cases of basal implants or bicortical. But in cases of conventional, you have to. Right? So, next difference, who are all eligible, right? Right? Or indications you can say, right? Who are all indicated, for the conventional implants. Now, frankly and honestly, please tell me, can you take a chance of placing, conventional or two-piece implants in a diabetic patient? Right? To just say it is easy, right? Why I am pointing it out, diabetic patients, right? A lot of times, the patients would have come immediately, will first jump up by seeing that the OPGR sound bone is there, let me just place an implant. Immediately you will order for, the blood investigations, and you find that his RBS or FBS is way beyond the normal values. All that excitement, it comes down. Right or wrong? Why? Because in cases of diabetics, now if you see in cases of diabetics, right, what happens in cases of diabetics or severe smokers, or in cases of periodontal diseases, right, or in cases of rapidly progressing periodontitis or an aggressive periodontitis, right, in such cases you actually cannot place a conventional or a two-piece implant. What is the reason? Right? There is only one reason, right? Now, if you see the next point, what is the kind of bone that is used for placing an implant, right? What is the bone that is actually used? Right? The bone that is used in cases of conventional or a two-stage implant system is the less mineralized cancellous bone or a spongy bone. Right? Right or wrong? Right? So, what happens there in cases of diabetics or in cases of severe smokers? Right? See, if any patient walks into you with severe smoking habit or whatever it is, right, just pass your probe around the crevices of the teeth, you will definitely find a deep pockets in them. Why? Because there is a marginal bone loss always, invariably, in all these cases. In cases of severe diabetics, or in cases of periodontal disease conditions, or in cases of like what do you say, uncontrolled smokers, right? All these people, right? So they have the marginal bone loss is there, very heavy, right? But why? The cancer, because of the nature of the bone that is being used in cases of the conventional implants. But if you actually see the difference here, means in the basal implants, right, the almost all the cases are eligible, right? You can do it in a diabetics, you can do in a smoker, right, or you can do in a periodontitis case also. Now why? because the term itself I have told you, right, we actually take the support or fix the implant in the heavily mineralized cortical bone. We are not at all dependent, right. Now to just pictorially to show it to you, right, now say for example, now this is your, okay, now, okay, now to just pictorially show it to you, right. Now if you see here, right, in cases of a two-piece implant system, right, you are actually relying more on the less mineralized, right, on the less mineralized cancellous bone, right. So your implant is here, right. But if you see in cases of the basal or the bicortical implants, right, heavily mineralized cortical bone, right, you are actually using a heavily mineralized cortical bone, means your, if this is the abutment, this is a shaft, but the actual fixating area is actually engaged into the deep cortical bone, right. So the chances of bone loss here, even if there is a marginal bone loss also, even if there is a marginal bone loss also, it is not going to affect the fixation of the implant system, right. But if you see in cases of a two piece or a conventional implant, right, if there is a marginal bone loss, right, if the threads are exposed, what will happen? The chances of failure of the implant increases manifold, right. Now you understood, right. So basically in cases of diabetics or in cases of heavy smokers or periodontal disease conditions, right, it's safer, risk free, that you actually use a basal or a bicortical implants rather than using a two piece or a conventional implant, even if there is a bone, because there is no guarantee, right. If you ask a smoker, right, he'll tell you, he'll just say that, are you going to stop smoking from tomorrow because I'm putting an implant? He'll say yes, 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 100% I'm not going to smoke, right. But can you guarantee even that he'll really stop smoking? I don't think so. Most of them don't, right. Similarly, the case of diabetics, the sugar levels or the blood glucose levels, right, they don't remain the same, right, they keep on changing, right. So there is no hard and fast rule that they will remain the same, right. So the chances of bone loss are more in cases of diabetics or in case of aggressive periodontitis, because in case of aggressive periodontitis, right, the first bone that is actually affected is the cancellous or the spongy bone, and because of which loss of the bone, and then the tooth eventually comes out, right. So it is most unreliable bone to use, right. But in cases of aggressive periodontitis also, now even if you would have seen a long standing edentulous cases, right, where you would have seen lot of people having a thin ridges also, right, the cortical bone is still intact even if he is a diabetic because of heavy mineralization of the bone, right. So that is most unreliable actually, right. So now very very important point, right, peri-implantitis, right, peri-implantitis. Now what is the term means, right, peri is the peripherals, right, of the implant surface, itis is inflammation, right. So inflammation around, right, the periphery of the implant surface is nothing but called as a peri-implantitis, right. Now it's very 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 important, right. And if you see most of the cases, right, most of the cases, right, if you have done a conventional or a two-piece implants, right? In cases of conventional implants, 99% I can say, right? The patient comes back with peri-implantitis in cases of two pieces implants. But in cases of basal implants, there is no chance of peri-implantitis happening. This is one of the major differences you can actually note down. Right? Now you might ask me, so what is the exact difference? What is it you want to tell us? Right? What is it you want to tell us, by saying that there is peri-implantitis in cases of two piece and there is no peri-implantitis in cases of basal implants, right? See, there are three striking reasons why actually peri-implantitis occurs in cases of two piece implants or a two stage implant, and it doesn't occur in cases of a basal or a bicortical implant, right? Now let us look at the major differences. Let us look at the major differences, right? The first and foremost difference is the surface of the implant, right? Now if you go back to the images, right, if you go back to the previous images and see, right, in cases of the two pieces implants, right, if you look at the implant surface, right, it is rough surface implants. The surface itself is rough surface implants, right? The rough surface implants, even if you look at the neck area also, right, even if you look at the neck area also, there is a roughness in the surface of the implant, because that roughness is actually created for the purpose of osseointegration, right? See, whenever you place a two piece implants, what is the physiology behind it? First, there is an osteoclastic activity because we are using the cancellous bone. Since you are using the cancellous bone, whenever a pressure or a compression is created, right, what happens is first osteoclastic activity will happen, after that osteoblastic activity will happen, right? So for that purpose, the surfaces are actually sandblasted, right, and various coating materials are applied onto it for a proper osseointegration, right? Because of this rough surface, right, if the surface of implants, actually the two pieces implants is actually rough surface. But if you see in cases of the the single piece implant or the basal or the bicortical implant, the surfaces including the threading area, means the area that engages into the bone, they are extremely polished surfaces. They are extremely polished surfaces, right? Now what is the significance of this? Right? What is the significance of this? See, whenever there is, how does a peri-implantitis first of all occur? Right? See, whenever, let us say for example in cases of two piece implants, right, whenever there is a marginal bone loss is there, right, the rough surface is actually exposed, right, the rough surface is actually at the neck area, right, at the neck area it is actually exposed. So whenever a rough surface is exposed to the oral environment, what happens? There is something called as a smear layer formation, right? There is something called as a smear layer formation, right? Now what does this smear layer do? Right? It is a fine thin film that actually forms on the rough surface. Now this smear layer will actually attract debris, right? Will actually attract debris, right? Will actually attract debris formation, right? And this debris formation will actually do what? Colonization of bacteria, right? So first and foremost, whenever there is a marginal bone loss exposing the rough surface to the oral environment, there is a formation of smear layer which actually attracts the debris formation. After that, the colonization of the bacteria occurs. After that, it leads to itis, means inflammation, right? There is formation of inflammatory markers and all this stuff, and then once in a while. That is the reason, for every, 2-piece implants you put, always call back the patient at least, every recall visit for at least for 6 months or 3 months, and do at least, a scaling or whatever it is, do a oral prophylaxis, and then you have to maintain it. Otherwise, what is going to happen? The implant will fail, right? One reason is what? Is the rough surface. Now, if you see in cases of, right, the basal or bicortical implant, the entire area of the implant from the abutment, right, from the abutment to the shaft to the engaging area, right, there is no rough surface of whatsoever, right. Let us assume there is a kind of marginal bone loss even in cases of, a diabetic or a periodontal disease condition, or in a heavy smoker, right, there is a marginal bone loss, let us assume, right, but still, because of the extremely highly polished surfaces at the neck region and the entire implant region, there is no smear layer formation, there is no debris formation, right, and there is no colonization, there is no, right, there is no colonization of the bacteria, right, and there is no inflammation. One of the major reasons that, you don't have, one of the major reasons that you don't have a peri-implantitis is the surface of the implant itself, right. So this point is clear, guys. I hope this point is clear to you, right. And what is the second most commonest reason, right, in cases of, why there is no peri-implantitis? What is the second most commonest reason? First one, the surface of the implant, right. Second most, reason, right, why there is no, you know peri-implantitis, right. Now, lot of you guys, if you see the surgical concepts, right, when doing a two-piece implants or a conventional implants, right, when you raise a flap, when you raise a periosteal flap for placement of an implant, the chances of peri-implantitis are very high, right. If any periodontist is sitting in the crowd, right, you will definitely understand what I am saying, right. The chances of peri-implantitis when you actually open a flap, right, is actually high, right. Simple example, even if you do a flap surgery, if you don't do a proper suturing, right, what will happen? There is a recession of the gingiva. Why does the gingiva recess? Because of the marginal bone loss, right. So whenever you are actually raising a mucoperiosteal flap, whenever you are raising a flap, the chances, right, are actually, you are actually increasing the chances of peri-implantitis, right. That is one reason. The other reason surgically, if you see, is the penetration diameter. The penetration diameter. Let us say you are not even, opening flap, for a two-piece implant. You are not opening any flap, right? But still, the chances, right, will increase actually because of the penetration diameter also. Now, what I am talking about penetration diameter is, now if this is the gingival surface, right? Now, if in cases of two pieces implants, now let us say if you are placing, a two-piece, right, implant, the penetration diameter actually will be more, because let us say if you are putting a 4.2 diameter implant, right, if you are putting a 4.2 diameter implant, right, you need to drill with a 4.2 right, at least up to the coronal half, right. So let us assume that you are not raising the flap, right, but the penetration diameter is approximately 4.2 right, right. But in cases of basal implants, the maximum drill that I am going to use, right, most of the cases I am going to use a very short, very thin diameter drill of approximately only 2 drill. Most of the cases. Rarely we use a 3 drill. That is the maximum size that I have used till date. Even for placing a 5.5 or a 6.5 mm diameter basal implant, right. So, just see, there is, even if you are using a 3 mm drill, right, the amount of difference between the penetration diameter of the surgical area. So, the more the penetration diameter, right, the more the chances of you developing, right, a peri-implantitis in the case are increased threefold, right, are actually increased threefold, right. So, this is the third and the most important, difference, right. And the last difference, this also is very, very important, right. The load bearing area, right, the load or the load transmitted area, right, is far away from the load affecting area, right. Now, I will just pictorially, draw it and show it to you, right, what exactly I mean by this, right. Now, let us say, now this is your implant, a two-piece implant, which is actually in the cancellous bone, right. Now, this is your tooth surface, okay, this is your bone, right. See, kindly, my apologies actually for diagrams, because I am not a good artist first of all, right. So, kindly bear with the diagrams what I am trying to do, right, trying to draw here, but I hope you will understand the, concept behind it, okay. So, now, this is the load bearing area, right. This is the LBA, okay, load bearing area, right. Now, the load bearing area, now this arrow mark is actually the load affected, means the affecting load giving area actually you can call, right. Now, if you see in cases of a basal or a bicortical implants, right. Now, let us take, this is the abutment, this is a tooth over it, right, and then you have a long shaft, but the load bearing area is somewhere here. The load bearing area is somewhere here, means the load bearing area is quite far away. The load bearing area is quite actually far away, located in the more reliable cortical bone, right, much more reliable cortical bone. It is located in much more reliable cortical bone. But whereas in cases of two-piece implants, right, the load bearing area, right, or the load transmitted area, you can other name, right, is actually located in the less reliable cancellous bone, right. That makes a hell lot of a difference actually. Owing to these differences also, right, the chances of peri-implantitis, right, actually, occurs very, frequently in cases of two pieces implants rather than in cases of the bicortical implants, right. So, let us just fastly, wind up, means round up all the differences, actually the major differences, that are happening, right. The first one is the fixation, right. In cases of conventional, it is osseointegration. In cases of basal, it is osseofixation. The success rate, right, is approximately 95% in cases of two-piece implants, right, whereas in cases of basal implants, it is 98 to 99%, right. And then the loading, right, is delayed loading in cases of conventional implants, whereas in cases of basal implants, it is immediate, right. Now, duration of time, right, it can go up to 6 to 8 months or 3 to 8 months, whatever, depending upon the condition of the patient. And in cases of the basal implants, within 72 hours, right. Now, why I am saying within 72 hours you have to, this is a very important point, right, within 72 hours you have to load it, right, within 72 hours you have to load it. If you don't load it within 72 hours, right, then the system might fail or will fail, I can say, right. Now, why you might ask me, why should I load it within 72 hours? The simple reason being, right, see, the physiology is quite exactly opposite when you compare with the cancellous and the cortical bone, right? In cases of cancellous bone, what is happening when you are actually placing an implant, right? The surrounding, actually there is an osteoclastic activity initially, right? After the due course of time, then there will be osteoblastic activity and then the bone formation and integration, right? But in cases of cortical bone, whenever you are placing an implant, right, in the first 72 hours there is a peak osteoblastic activity. So if you want to take the advantage of it, right, you have to, load it within 72 hours, because when you actually have a physiological loading, right, it actually it actually fixes more because of the increased osteoblastic activity within 72 hours, right. Please keep this point in mind, that within 72 hours, the maximum time period what you can wait is 72 hours. So whenever you're planning a case for a basal or a bicortical implant case, make sure that your lab technician is ready, right. Tell him that you're going to have a case, you're going to operate a case, and then within 3 days you have to give him the teeth, right. So keep everything ready and then only plan the case, post the case and then do it, so that you'll have a more higher success rate. Is that clear, guys? Right? So, and then obviously, sizes and designs, as I was mentioning, right? There are multiple sizes and designs in cases of basal. There are limited sizes and designs in cases of conventional implants, right? And obviously, the bone augmentation, all these things you can totally avoid. Mark my words. You can actually totally avoid, right? Actually, I shouldn't say this. Thanks to COVID, actually, we surgeons, sometimes we had a partial maxillectomy cases, right? In those cases, we did not require to do any kind of grafting, but we still could be able to rehabilitate the patient, with both functional and aesthetics also, by placing implants, by putting zygoma implants, or by even utilizing the pterygoid bones, right? By using basal implants, where the two-piece implants was not possible, right. So such things, right, all these things can be avoided, which are actually required in cases of two-piece implants. Is that clear, guys? Right. So, and then as I said again, eligibility of the patients, right, almost all, every case is indicated for basal, right, including diabetic, smokers, right, or a periodontitis case. Every case is actually indicated in cases of the basal implants, but in cases of conventional implants, not suitable for diabetics. Don't take that chance, right. And even smokers, chronic smokers, what I mean, or habitual, they cannot stop their addiction, right. And periodontitis cases, and the bone used, very important, highly mineralized bone in cases of the basal, and less mineralized or a cancellous bone in cases of conventional, right. And the last one, the peri-implantitis case, right. Peri-implantitis, if we see, it is widely prevalent in cases of conventional, and there is no peri-implantitis whatsoever in cases of basal, owing to the three reasons. First is the implant surface, second is the penetration diameter, of the surface of the gingiva, right, or the surgical site, and lastly, right, is uh, the load bearing area being very far away in the most reliable zone in the cortical bone for the basal implants, and the load bearing area of conventional implants actually is in the less reliable cancellous bone, right. So these are the important differences, right. So guys who are all practicing two-piece implants, right, please note all these differences, right, go through them once again, right. Any doubts in these differences, also you can note it down, you can jot them down in your own diaries or notepads or whatever it is, right. And then whenever we have a QA session, right, definitely I'll clear all your queries, right. There won't be any question that will be left out, and I'm sure that definitely from my side I will give you what all the knowledge you want, right. because I want you to practice basals as soon as possible, right? And coming to the last thing about, there are few contraindications actually even for basals also, right? Now there is a controversial statement, right? I said almost all the cases you can do, right? All the cases you can actually do, right? But there are actually absolute contraindications for any kind of an implant, be it a two-piece or a bicortical. You cannot place an implant, right? So now, what are these conditions actually, right? First and foremost, right, is a radiation therapy, right? If the patient is undergoing any kind of radiation therapy, right, any kind of radiation therapy, please don't do any kind of implants for at least an year after the last cycle of radiation, right? See, I'll just tell you a small incident that happened in my own life, right, so that you will understand why I am reiterating this point, right? There was this one young lad, he was just only 22 years old, and he was having an osteosarcoma of the mandible, on the right side of the mandible, right? So since as a surgeon I know that I should not give any kind of reconstruction plate or something like that, right? But it was young in my career actually, when I way back in 2011 or 10, right? So that time when I was too young actually into the career, he insisted, no sir, all their parents came, right? Because in the cases of osteosarcoma you need to resect the mandible, right? You have to put him on a radiation therapy and then give him a chemotherapy, because the survival rate of osteosarcoma is only 5 years, right? Thank God he still survives. Even after 13 years he is still there, right? But you know what the mistake I have done, right? I am talking about a titanium plate, because we are actually going to put a titanium implant. The same example I am just trying to tell you, right? So their parents came, they fell on the feet. You know about all this drama that the patients do, right? Right? He was a young boy, so they did not want any kind of asymmetry on his face, right? So somehow I succumbed to their pressure, right? So once I did the resection and all, I put titanium reconstruction plate, right? And I sent him for radiation therapy, right? Exactly after post radiation, after 3 months, right, he came back and the plate was severely exposed here, right? And all the saliva started drooling out, not from the mouth, actually from the lower half of the mandible, all the saliva started coming out, and the remaining chunk of the bone, that was actually, means we actually resected from condyle to the second premolar region, right? So the first premolar, that bony chunk will be there, no? It also started exposing. There was a lot of wound gaping, right? So I had to take him again into the OT. This is post radiation 3 months, right? So I had to remove the reconstruction plate, but still, even till 6 months after the second surgery, it did not heal. There was still a fistula formation, bone exposure. Every 3 days I used to call the patient, irrigation done, all these headaches will be there if you do, in implant, a simple implant, even if you put in the radiation cases. So please, it is an absolute contraindication, right? It is an active, if there is absolute contraindication, if the patient is on radiation therapy, don't do any kind of an implant. I am not talking about basal, I am not talking about conventional, any kind of implant, please don't do it. Simply say, no boss, go, come after 1 year. So the minimum time period you have to wait is at least a year, right? So now what is the second absolute contraindication? An active pathology. If there is an active pathology, now let's say for example, a keratocyst, a simple keratocyst, right? It might look simple, but a lot of you guys will understand, right? You would have read all this. The cyst with the highest recurrent rate is a keratocyst, odontogenic keratocyst, right? If there is a keratocyst, don't just do simple curettage, basal bone, no, I will do it, no, right? And not just the odontogenic keratocyst, if there is an ameloblastoma or if there is a dentigenesis, any active pathology is there, right? Please don't do any kind of an implant. First treat that, give a 6 months time period, then only do basal or whatever the implant you want to do, right? So this is the second and the most important contraindication. And the third, and this third contraindication, I am sure most of you will actually ignore it because you don't know it, and you would have treated such cases also, right? See, there are this lot of cases actually, who have the skin problem of psoriasis, right? Now a lot of people walk in with psoriasis sometimes, right? So whenever a psoriatic case comes to you, don't just rely on the patient's words. Don't rely on the patient words, right? Find out the history of the patient, what is his medication, and if you find a drug called as methotrexate or any kind of biphosphonates, right? Biphosphonates generally in anti-cancers, right? So if you find this drug called as methotrexate, right, please don't do implant, because either biphosphonates or methotrexate, because nowadays to treat psoriasis also methotrexate is being commonly given, right? So please don't take that chances, you will be in soup, because these two drugs, biphosphonates or methotrexate, they have, they reduce the osteonal activity, they increase the osteoclastic activity in any kind of bone, not just cancellous, even cortical also, right? If the patient is on the drug, so the minimum waiting period, if the patient has to continue that drug post, the last dosage of these drugs, at least give a 1 month time period, 1 to 1.5 month time period. After that, again you can place an implant, right? So please guys, remember these contraindications. Other than these three, you can actually do it in any case, right? These three are very, very vital, right? One is the active pathology, right? Please don't do, right? Second is the active radiation therapy is going on, please don't do. And third is this drug methotrexate, please remember this drug methotrexate. If you come across the patient who is using this drug, please don't do any kind of implant, not at all required, right? So with this, uh, you know I actually thank you very much, all of you, for your patient listening, right? And registering yourself for this module. Whatever the brief, introduction about the conventional implants I could give, I have shared this, right? In the next module, right? Very important. In the next module, we'll be dealing with more about the anatomy, because that is more important for all of us, because without knowing anatomy we cannot place anything, right? Not just two piece or even a basal, nothing you can do, right? So when we are going to conduct the second module very soon, very shortly, you will get the dates and time, right? Mostly it will be in the same time zone, like 7 to 8:30 p.m., right? If there is any change, right, we'll definitely let you know about it. And when probably in another 2 3 days or 4 days, we'll have the second module also, because I don't want to give much of a gap, because we all tend to forget, right? So I want it to be like a flow, right? So once again, thank you very much guys, for your patient listening, right? And I hope that little concepts I was able to actually convey to you about the basal and the conventional implants, right? And as we go ahead in the from module to module, right, you will actually have much more clarity, right, about the basal implants. So thank you once again. Good night all of you.